Continuing on with inflammation of the lower GI tract, we're going to now cover cirrhosis, hepatitis, and cholecystitis. And as we go through these exemplars and thinking about the previous two exemplars we have already discussed, consider what the similarities are between them, because this is an exemplar called inflammation. So let's think about what the similarities are in each of these diagnoses. The objectives are the same as what was in the previous slide. I've just taken out the other two exemplars so that we're focusing on cirrhosis, hepatitis, and cholecystitis. I've included a schematic of the liver and gallbladder for our referencing as we think about where these organs are located in the GI tract. And you can see the gallbladder is kind of tucked underneath the liver there. And it's got that common bile duct there. Let me see if I can do this. A common bile duct that gets occluded. So we're going to talk about that later. And then, of course, the big liver organ here. What is cirrhosis? It is an extensive, irreversible scarring of the liver, and it's usually caused by chronic reaction to inflammation and necrosis. It has a progressive, prolonged, destructive course leading to end-stage liver disease. The most common causes of them are listed here. There's, of course, the chronic alcoholism. That's probably the one that we all think of the first and the quickest. But then there's chronic viral hepatitis that also will influence that and create that inflammatory response. There's also non-alcoholic steatohepatitis and bile duct disease and genetic diseases. So it's not always alcohol, although that is probably the most common one. The pathophysiology of this is a chronic inflammation that's caused by either toxins, alcohol, or disease, which results in degeneration and destruction of the hepatocytes, fancy word for liver cells, hepatoliver cells. The tissue becomes nodular, and these nodules block bile ducts and normal blood flow. So imagine those bile ducts being blocked and blood flow being, I have not had anything to drink, but I'm ready. I'll tell you, I still can't talk. Normal blood flow, when that's all blocked, what's going to happen to the organ behind that? It's going to get enlarged, right? And that's what happens. The liver is usually enlarged, firm, and hard in the early stages. Eventually, it will shrink in size, and this results in the decreased liver function. Of course, lab-wise, we're going to see elevated serum liver enzymes, and some patients will have no symptoms at all until it's serious. The type of cirrhosis is based on the cause of the disease. So post-necrotic cirrhosis is caused by viral hepatitis, mainly the hep C, and certain drugs and toxins. Lennox is also called alcoholic cirrhosis, and Lennox was either the first alcoholic to have it or the guy that named it. I'm going to go with Lennox named it. I don't know. I didn't look it up. Biliary cirrhosis is also called cholestatic, and it's caused by chronic biliary obstruction or autoimmune disease. So there's many causes, and not all of them are, like I said, not all of them are alcohol related. The complications of cirrhosis will depend on the amount of hepatic damage that has occurred, which of course makes sense. There is compensated and decompensated cirrhosis. In the compensated cirrhosis, the liver is scarred, but it can still perform its essential functions, and so they don't have major symptoms. They may not even know that they have any liver scarring because they're functioning just fine for a while. Decompensated cirrhosis is where the liver function is impaired and these symptoms are obvious of liver failure. And this can lead to these problems that I'm going to talk about next. We'll start with portal hypertension. Now I want you to picture in your mind the liver and the blockage of the portal vein. If you need to go back to that slide, go back to that slide. But realize that if the blood flow is blocked through that portal vein, you're going to get that increase in pressure within the portal vein. This will cause the blood flow to go back into the spleen, which causes splenomegaly. The spleen will get enlarged. This causes a destruction of platelets, which the spleen is responsible for platelet formation, right? And if we start destroying those, what do we get? Thrombocytopenia. So that's one of the possible outcomes for portal hypertension, portal being the portal vein. The abdominal veins also become dilated due to this pressure, and this results in ascites, abdominal fluid ascites. It also will result in esophageal varices, prominent abdominal veins, and hemorrhoids. Now, hemorrhoids, yeah, they hurt. They're not going to kill you, but these esophageal varices are the most concerning possible complications. We'll talk about those in a minute. But just picture all that fluid going in, the abdominal veins getting all dilated because of that backflow and trying to accommodate all that extra fluid there. And so it's going to have that fluid shifting into the abdomen. With ascites and gastroesophageal varices, we're going to talk about those now. The above complication that I just mentioned, it then causes a reduction in the amount of circulating plasma protein in the blood. And this results in a decrease in the serum colloid osmotic pressure. If you reduce the plasma proteins, you're going to reduce that pressure, which eventually results in a fluid shift from the vascular system into the abdomen, which is known as third spacing. So that's where the ascites comes from. The patient, this is weird, guys, but realize the patient has both hypovolemia due to this, but also edema. So it's a very strange symptom that they will have. Massive ascites can massive ascites can occur, which can result in renal vasoconstriction. So the kidneys get less blood to them. This will trigger that renin-angiotensin system. Then sodium in water gets retained, which causes an increase in the hydrostatic pressure and vascular volume, and you get more ascites. So it is a huge, what's called a positive feedback cycle. Not that it's a positive result, but that's what's known as a positive feedback cycle. It just creates its own issue, keeps going. The esophageal varices occur due again to that backup of blood from the liver to the esophageal and gastric veins. And bleeding esophageal varices is a life-threatening emergency. These patients can bleed out very, very quickly. Severe blood loss can occur, and then of course they go into a hypovolemic shock. Blood may be lost via vomiting. You'll see hematemesis, or the stools, which is the melena, that bloody stools. Any activity that increases abdominal pressure may increase the possibility of occurrence. So these patients need to be very strictly counseled on no activity no heavy lifting, this is not the time to start exercising. They need to just keep their bodies as loose as possible. Chest trauma or dry, hard food in the esophagus may cause the varice to break open if it's scraping. So very much I'd even go on a soft diet. That would be my recommendation. I didn't read that, but it makes sense to me. Coagulation defects are another complication that can occur. We've already mentioned the thrombocytopenia, but additionally, due to the decrease in the production of bile, the absorption of fat-soluble vitamins, of which vitamin K is one, is decreased, and we know vitamin K is necessary as part of the coagulation system. So that is a decrease in clotting factor, and so clotting factors are not produced in sufficient quantities, so they experience this coagulation defect. I know jaundice, everybody knows you got liver problems, you got jaundice, okay? What causes it? Do you know that? We're going to learn that right now. It's caused by one of two mechanisms. One is due to not being able to excrete bilirubin, and the other is because there's a blockage. So the hepatocellular disease is that disease causes bilirubin because the liver cells cannot effectively excrete it. They're diseased cells. In intrahepatic obstructive jaundice, this is due to edema and fibrosis, that scarring of the hepatic bile channels. So there's a mechanical obstruction versus a cellular disease. The obstructive jaundice patients often will complain of itching because of that collection of bile salts. Another complication is called portal systemic encephalopathy with hepatic coma. And these, of course, are very, very sick people. The pathophysiology of it is not clearly understood, but the information I read says it may be a result of shunting of that portal venous blood into the central circulation and therefore bypasses the liver. The liver detoxifies poisons and neurotoxins that we may accidentally ingest. So if the liver can't do that, then the mentum, the neurological brain system is getting exposed to chemicals that are causing harm. Symptoms that the patient will experience: they'll complain of sleep disturbances, mood disturbances, mental status changes, and speech problems. Starting to think maybe that's what I have. No, I'm kidding. Later neurological symptoms, they will go into altered level of consciousness. They basically become comatose. They may have impaired thinking processes. They don't make sense, okay? They have neuromuscular problems. Their body doesn't respond appropriately to walking and signals to bend over, pick something up. They're unable to do that. And there are 4 stages of development of this encephalopathy, which I'm not going to go into, but I do refer you to page 1194, table 58.2, that will talk about these 4 stages. I think it's important not to memorize them, but to really kind of get in your mind how severe the disease is at each stage. Could you recognize which stage a patient is at based on that chart, that table? Contributing factors to this problem are high protein diet, infection, the hypovolemia, hypokalemia, constipation, GI bleeding, drugs, specifically hypnotics, sedatives, opioids, analgesics, diuretics, and illicit drugs. Lots of things will contribute to it. The final 2 complications of cirrhosis are the hepatorenal syndrome and spontaneous bacterial peritonitis. Hepatorenal syndrome patients have a very, very poor prognosis, and it's often the cause of death. You will see a very sudden decrease in urinary flow, less than 500 mils in a day. And if you remember I'm pretty sure I've said it in class. I know I have. If I've got good kidney function in my patient, I know we have time to deal with whatever they're dealing with. But these patients, you can see they have not much kidney function left. In labs, you'll see the elevated BUN and creatinine and abnormally decreased sodium levels. And they also have an increase in the urine osmolarity. Spontaneous bacterial peritonitis. This may be the result of low concentrations of proteins. Proteins normally provide some protection from bacteria. And the bacteria responsible for this peritonitis are usually bowel in origin, and they reach the acidic fluid in the abdomen through the lymphatic system. The signs and symptoms are going to be the fever, chills, abdominal pain, and tenderness. The etiology of cirrhosis and the genetic risk we'll discuss briefly here. Hepatitis C is the most common cause of cirrhosis and liver failure in the United States. So it's not really the alcohol, it's hepatitis C. This infection eventually causes scarring, and you will see later on that hepatitis C infections are on the increase in our country. We'll discuss that in a minute. Hepatitis B and D are the most common causes of cirrhosis worldwide. We don't have D here, but B we do have, and anyway, we'll talk about that shortly. Excessive and prolonged alcohol use is again an etiology, as you know. Alcohol has a direct toxic effect on hepatocytes, and it causes liver inflammation. Early scar formation does occur, These patients often are malnourished because they're drinking instead of eating healthy food, and this malnutrition and repeated exposure to alcohol causes progression of damage. Stopping the alcohol consumption will cause the inflammation to reverse. So it's really important if we can teach these patients to help them get off alcohol and any of the drugs. The non-alcoholic fatty liver disease. It is increasing in occurrence in the United States. I never heard of this before I met my dad's wife, and she had it and she dealt with it and she's doing better. She's fine now. But what an interesting disease, and it's on the increase in our country. My dad's wife is not obese, but it's associated with obesity and diabetes type 2 and metabolic syndrome. But as with Nancy, sometimes it's there. We have no idea why. I mean, she doesn't have any of these risk factors. It is the most common cause of liver disease in the world. It can progress to cancer, cirrhosis, or failure and result in premature death. And this is amazing when I read this. Up to 25% of Americans may have non-alcoholic fatty liver disease. I never heard of it, and now all of a sudden everybody's got it. Hispanics are the most susceptible culture group. And that's interesting because they actually eat pretty well, I thought. I don't know, rice, beans, tacos. The incidence of cirrhosis, more than 30 million people have the liver disease in the United States, which is about 1 in 10 Americans. There are 50 of you guys in this class, so 5 of you are going to have liver disease in your future. Interesting, huh? Kind of freaky interesting. 4 million Americans have hepatitis C, and more than 1 million have hepatitis B. The incidence of chronic liver disease and cirrhosis added together is the 12th most common cause of death in the United States. And there are about 28,000 deaths of adults each year due to liver disease. How do we do an adequate assessment on patients who we are concerned with or who have cirrhosis? I've listed several of the things here. There might be more that you can think of, but age, gender, and employment history. What does employment history have to do? Do they miss work because of being sick? That may give us an indication. And also, where have they worked? Have they worked in areas that they would be at risk for developing exposure to chemical toxins? Okay. What is their exposure to alcohol, drugs, chemical toxins, illicit drugs? Are they in the healthcare field? Do they have exposure to needle stick injuries? Are they an IV drug abuser? Do they share needles? What is their sexual history and orientation? Family history of alcoholism and or liver disease. Is there a family history of alcoholism? As you know, you may not know, but alcoholism does tend to have a hereditary aspect to it. Have they been in the military? They're high risk. A lot of those guys get tattoos. And when and where were they done? Were they done safely? Were they in prison? Prisoners, I don't know, they use weird stuff to give themselves tattoos. So they're at high risk for developing inflammation and liver problems. Again, mentioning the healthcare workers, firefighters, police officers are at risk because of the clientele that they work with. If the patient is in recovery, how long have they been sober? Very important to know that. Previous medical conditions that may impact their status at this time would be any history of jaundice or acute viral hepatitis, any biliary tract disorders such as cholecystitis, gallbladder problems, viral infections, surgery. Have they ever received a blood transfusion? Blood transfusions prior to 1992 were not tested for the common viral infections of HIV and hepatitis. So unfortunately, some people died because of receiving blood that was infected. Do they have a history of autoimmune disorders which would make them more susceptible to infection? Are they obese? Do they have an altered lipid profile? Have they ever received counseling to lower cholesterol? Or had been advised to be put on cholesterol medications? Heart failure, respiratory disorders, or liver injury. All these are important, important information to gather. The physical assessment. Many of the early manifestations are vague and nonspecific. Who does this remind you of, right? Fatigue, significant change in weight, GI symptoms such as anorexia and vomiting. That's you guys before an exam, right? Abdominal pain and liver tenderness. Hopefully you're not that bad. The cirrhosis, the altered liver issues, a concern with the liver may not even be discovered unless there's a routine lab testing done. I know we're at a certain age encouraged to get yearly lab work, and you're like, well, I feel fine. Well, and then you get your lab work done, you find your liver enzymes are off. That's how Nancy was. She was fine. She didn't feel bad. So it may be discovered only as a result of routine lab work. Patients with that compensated cirrhosis may have no idea until they get lab work done. It is in the late stage of the disease when patients usually seek treatment, and the treatment they would be the reason they would come in would be evidence of GI bleeding, jaundice, ascites, abdominal pain, abdominal swelling, spontaneous bruising, which would indicate your thrombocytopenia problems, right? We want to assess them for jaundice, dry skin, any rashes, petechiae or ecchymosis, palmar erythema, spider angiomas, ascites, peripheral dependent edema of the extremities, and the sacrum, interestingly enough. And let's do vitamin deficiency studies. Let's do some lab work. Physical will also include an abdominal assessment, checking for ascites. I put orthopnea and dyspnea there. Why would they get orthopnic and dyspneic? Because with the ascites, the lungs have less volume to expand, so they're going to have shortness of breath. Bowel sounds, listen to them. They may be diminished. Evaluate for abdominal wall rigidity. Do their vital signs. Low-grade fever sometimes accompanies cirrhosis. Loss of appetite. These may indicate spontaneous bacterial peritonitis, which is really serious. That's a severe complication. More assessment would be their posture. Do they have problems with balance, indicating the neuro involvement? Inspect and palpate for inguinal or umbilical hernias. Why do you think they might have hernias? What makes sense to you? I want you to tell me. Hepatomegaly occurs in early cirrhosis, as we mentioned, and splenomegaly is common in the non-alcoholic causes. Okay. We want to measure their abdominal girth and make sure we indicate specifically where we measured on the abdomen when we record it in the chart. So when we do comparison measurements to see if we're getting better, we'll be measuring the same part of the body. We do daily weights. That's very indicative of progress, hopefully. Observe any vomitus for blood, or have the patient be sure to observe for that. Do a fecal occult blood test. Notice their breath odor. If it's fruity or musty odor, that may be an indication of chronic liver disease and hepatic encephalopathy. If it is a foul odor, that could be infection. Okay. The menses history, or are they amenorrheic? That's important for the female patients. Men may have testicular atrophy. They may have gynecomastia, which is an enlargement of the breast tissue, and they may be impotent. Bruising and petechiae, you know why that can happen, right? What is their neurological function, their mental status, personality changes? Just observe them and how they respond to the questions. Asterix is a coarse tremor. It's a rapid, non-rhythmic extensions and flexions in the wrists and fingers. It's like hand flapping. If they're doing that, they're sick. There's neurological involvement. The psychosocial assessment will include, again, the personality changes and changes in cognition and behavior. Are they agitated? What are their sleep pattern? Do they have disturbances? Any difficulty sleeping? Emotionally labile. Those patients are always at the end of their rope, basically, and ready to lose it. Or they go into euphoria or depression. It's almost like a manic or manic depressive type behavior. The mind can go either way. If the patient is alcohol dependent, we want to know that because they're going to go through withdrawal and get physical symptoms from that. The diagnostics that may be done would be x-rays and a CT scan, the MRI. The ultrasound is often the first assessment to detect the ascites, hepatomegaly, and splenomegaly. So it is pretty much the one that they want to do. It would also detect any biliary stones of ductal obstruction, and it will also indicate or find portal vein thrombosis if that exists, and then if the direction of the blood flow is normal or is it doing that backflow, which is going to progress to all those other backflow problems of ascites and that we talked about. A biopsy may be indicated to determine the extent of the disease progression, but caution is needed because they are at risk for bleeding. So you go in there and you're making, not you, but the surgeon is doing his surgery to go in and making areas where the bleeding can occur. They can bleed out through those areas too, so it must be done very, very cautiously. Labs to be done would be the AST, ALT, and LDH levels. If those elevate, then you suspect liver is being affected. As the liver deteriorates, these levels may appear to be normal as the hepatocytes are unable to create the normal inflammatory response. So initially you may have an elevation of those enzymes, but then as the liver gets less effective, those enzymes can't be made. So it could look normal, but it's really not. It's a result of a sick liver. The AST-ALT ratio is great if it's greater than 2. This is usually found in alcoholic liver disease. So look at your those two levels and see if the ratio is greater than 2 to 1. Serum bilirubin levels will rise, and you'll see bilirubin in the urine and in the stool. The total serum protein and albumin levels will decrease due to the decrease in synthesis by the liver. It can't synthesize it, so it doesn't get utilized. The prothrombin time is prolonged because the liver decreases the production of prothrombin. The platelets will be low, which we've mentioned, and they're also going to have a decrease in the red blood cells, hemoglobin, hematocrit, and in the white cells. What is the treatment for cirrhosis? The management is focused on preventing or minimizing ascites. Vitamin supplementation will be indicated, specifically thiamine, folate, multivitamin. MVI means multivitamin. Those would be added to the IVs. The liver cannot store these vitamins, so they don't have them. I mean, the liver can't get it, cannot provide them. The nutrition therapy, we recommend they be on a low sodium diet, about a 2,000 milligram a day restriction, and we can suggest to them alternate flavorings to their food. Eventually the low sodium won't bother them, but initially if they're heavy on the salt, they're going to not like their food. So we can encourage them to try lemon, vinegar, parsley, oregano, pepper, different varieties of flavorings. And I know Mrs. Dash has lots of different type flavorings that do not include sodium. So they can get creative with that. Drug therapy may be used. The diuretic of furosemide and spironolactone is a combination therapy that's frequently used. The drug therapy, these diuretics may result in a fluid electrolyte imbalance, so they must be constantly monitored for signs of dehydration, hypokalemia, and hyponatremia. The quinolones, such as noroxen, if they develop that bacterial peritonitis, or they use Bactrim if they're allergic, so they'll be put on an antibiotic to help minimize that bacterial peritonitis. Paracentesis may be done to remove acidic fluid from the peritoneal cavity to reduce the pressure of that fluid, depending on how much is in there. And if they're going to do that, they'll probably send a specimen off for culture, especially if they consider or are concerned about the bacterial peritonitis. Respiratory support. Remember, they're having trouble breathing, so we want to auscultate their lungs every 4 to 8 hours and listen for crackles, listen for sounds of wet lungs. Monitor their O2 sats. Elevate the head of bed to whatever degree is comfortable for the patient. Elevate their feet to help prevent edema, keep the blood circulating. And of course, close monitoring of the fluid and electrolyte balance must be done. With hemorrhage as one of the possible complications that can kill these people, we must figure out how to, or we must learn how to control and help them. All patients with cirrhosis should be screened for these esophageal varices by an endoscope to detect them early. If bleeding does occur, they can be treated by combining vasoactive drugs with endoscopic therapies. For example, vasopressin and statin, these will reduce blood flow via vasoconstriction, so it minimizes the amount of blood getting to the varices. And the endoscopic therapy will be ligating the bleeding vessels, trying to stop them from bleeding. Another method to do as endoscope would be sclerotherapy, and this is where they inject a sclerosing agent via a catheter to the bleeding vessels to stop the bleeding that way. Kind of like cauterization, but not cauterization, because it's done with a sclerosing agent. If varices are present, the patient will be placed on preventive therapy. Drug therapy may be initiated, specifically propranolol or indirol, which is a beta blocker. This will decrease the heart rate and hepatic venous pressure gradient. So they're minimizing that pressure that's happening, that's promoting the bleeding in the first place. Up to 20% of cirrhotic patients who are admitted for upper GI bleeding have bacterial infections. These patients are at high risk to develop UTIs or pneumonia. Infection is the most common indicator that patients will have an acute variceal bleed. Therefore, they need to be treated with antibiotics when admitted. High risk situation if they have infections and they have cirrhosis. How to manage the hepatic encephalopathy. Interventions are aimed at slowing or stopping the accumulation of ammonia in the body. That's the main assaulting agent. Ammonia is formed in the GI tract by the action of bacteria on protein. So treatment is focused on preventing or decreasing ammonia production by dietary limitations and drug therapy. So hang with me here for a minute. These patients will be on diets that have only a moderate amount of protein, fats, and simple carbohydrates, okay? Drugs are used sparingly due to liver damage, right? They cannot metabolize them, so we can't just throw a lot of drugs at them. We need to restrict the opioids, analgesics, sedatives, and barbiturates, okay? The drug therapy is most useful for reducing and eliminating ammonia production, and that's when it should be used, is to prevent the life-threatening problem with encephalopathy. Lactulose or lactitol and non-absorbable antibiotics are often used. Lactulol promotes excretion of ammonia in the stool, and it's given either orally or by NG tube. So that's going to help get the ammonia out via the stool. Liver can't do it, right? The purpose is to obtain a laxative effect. So we have to observe them and ask them about intestinal bloating and cramping, maybe kind of warn them that may happen and to report it if it does. But that's what lactitol will do. We also need to monitor the elderly for adverse effect of over-elimination. In other words, if they're stooling too much, they can become very weak and dehydrated very, very quickly. So be very careful in our elderly population. Home management of cirrhosis, let's prepare them for home therapy. We want to assess their physical adaptations that are needed to prepare the home for recovery. They might need a referral for physical therapy, nutrition therapy, transportation services if they can't drive because they're an alcoholic or they're, who knows what the situation is. Let's make sure they can get to their physicians or their medical appointments. Interestingly, we got to make sure the patient's area where they're resting, where they're recovering, is close to the bathroom because they're going to be pooping and peeing a lot, okay? The diuretic and the lactulose therapy are going to cause them to need that bathroom a lot. Some of them will actually need a toilet, portable toilet put near the bed if that's the way they have to get close to it, okay? And they may need incontinent pads or briefs. Discharge teaching, we'll talk to them about the nutrition plan specifically that we've mentioned. Drug therapy education specifically for them will be the diuretics. Of course, we want to always teach our patients who go home on medications the why, how often, side effects. So that's very important for these patients as well. Really encourage alcohol abstinence if they are an alcoholic-induced cirrhosis. If it's not alcohol-related cirrhosis, they don't have to abstain, but most of them will. If they don't drink anyway, why would they start now? They may have a drain in their abdomen to drain off ascites fluid to help reduce that pressure. And if they do go home with a drain, then they need to learn how to take care of that. Encourage them to eat small, frequent meals. Those may be tolerated the best. The vitamin, supplemental liquid feedings, PRN, such as Ensure, may be necessary to help keep their nutritional status up if they can't eat much. They need to avoid excessive vitamins and minerals because they can become toxic to the liver, and specifically those fat-soluble vitamins, the iron supplements, and niacin must be very, very minimal, if at all. Teach the family regarding what to look for related to the encephalopathy because they may be the ones that identify it. The patient may have no knowledge that they're acting weird, okay? Bleeding and infections can increase this risk, also the constipation, so the family needs to be educated about that. The patient should be instructed to avoid all over-the-counter meds, including herbs. You know, herbs are not without potential risks, so just avoid them. The liver can't handle it. Reinforce them to keep their appointments and to have them notify their healthcare provider of any signs and symptoms of GI bleeding, such as throwing up blood or noticing dark black stools or even frank blood in the stool. In summary, our cirrhosis outcome goals will be to have a decrease in or no ascites, to have the electrolytes be within normal limits, to have no hemorrhage, or if they do, we'll manage them immediately if it happens, do not develop encephalopathy or will be managed immediately if it occurs, have the highest quality of life possible for as long as possible, and to successfully abstain from drugs, alcohol, and drugs. And now we're going to talk about another liver problem called hepatitis. And what is this? Hepatitis is a widespread inflammation of liver cells. The most common type is viral hepatitis, and that can be either acute or chronic. It's the most common type, and we'll talk about them individually. The less common types would be caused by chemicals, drugs, and again, some herbs. Viral hepatitis can be caused by hepatitis A, B, C, D, or E. And some viral hepatitis is non-A, B, C, D, or E type. So it doesn't exist with that, it's just a different type. We're not going to talk about that one. Liver injury and inflammation can occur after exposure to drugs, chemicals, by inhalation, ingestion, or IV administration. So those are some initiating things to causing that liver injury. Industrial toxins, alcohol, and drugs can cause toxic and drug-induced hepatitis. They may also occur as a secondary infection due to other viruses such as Epstein-Barr, herpes simplex virus, varicella zoster, or the chickenpox, and cytomegalovirus. After the liver is exposed to any causative agent, it gets enlarged and congested with inflammatory cells. So the liver gets all puffed up, and the lymphocytes and fluid and inflammatory cells all get congested in there, and it results in right upper quadrant pain and discomfort. As the disease progresses, I guess that's my cat. I'm sorry, guys. My dog has that esophageal tumor, and I thought he was gagging, and it's my cat. He's doing a cat thing. I'm so sorry. All right, back to work. Let's see. As the disease progresses, the liver's normal lobular pattern becomes distorted. Okay, so the normal tissue of the liver become distorted as a result of the inflammation. Necrosis can happen, and hepatocellular regeneration will occur. This distortion increases pressure within that portal circulation, interfering with blood flow into those hepatic globules. So all that distortion interferes with that pressure, and edema of the liver's bile channels results in obstructive jaundice. So it's very similar to cirrhosis. It's the pressure and edema, all that is impeding the liver's ability to do its job, to let fluids come in and out and go where they're supposed to go. There are 5 major etiologies of hepatitis, and these 5 types vary by mode of transmission, manner of onset, and incubation periods. We're going to go through each of these 5 one by one. First one is the hepatitis A, and the causation is an RNA virus of the enterovirus family. This is a hardy virus that survives on human hands, interestingly. It's resistant to detergents and acids, but it is destroyed by chlorine and extremely high temperatures. Disease can cause this. It's spread most often by the fecal-oral route. I always get grossed out when I read that. Or consuming contaminated food or water. Shellfish caught in contaminated water can be your method of getting this. Food handled by persons infected with hepatitis A, that is probably the most common reason that we get it, okay? That's why you should wash all of your food really well when you get it home, maybe with chlorine, I don't know. Incubation period is 15 to 50 days with a peak at about the 1 month mark, 25 to 30. It's usually not life-threatening, that's the good news, but it is more concerning in those older than 40, those with pre-existing liver problems. Also, those that have a decreased immune system. I thought that was on here. I don't know why it's not on here, but that would be another reason it's more concerning. The incidence is particularly high in the non-affluent countries that have poor sanitation. There are over 35,000 cases diagnosed each year in the United States, and the course of the disease is similar to the GI illnesses. I'm going to guess that you're going to start hearing more hepatitis A coming out of the lovely state of California due to the sanitation conditions there. I don't know if you know this, but people are pooping in the streets because they don't have homes. So they're pooping in the streets, and there's no problem with that. They have poop charts, poop maps. I know you didn't want to know that, but don't go to San Francisco right now. But I'm going to guess that the hepatitis issue is going to go up. Seriously. Hepatitis B is composed of 3 antigens. That's the hepatitis C antigen, hepatitis S antigen, and hepatitis E antigen. That's the core, surface, and another core antigens. You don't need to know all those. We always call it hepatitis HBsAg. That's the one I always call it when I'm ordering it. It would always be the hepatitis surface antigen. But there are 3 antigens in there. The method of transmission for that is the unprotected. This is a sexual transmitted one. This requires very close person-to-person contact. Unprotected intercourse, sharing needles, accidental needle sticks, for example, in the healthcare industry, in the OR, in giving an injection. Blood transfusions prior to 1992 when they did not test for hepatitis. I don't know if you even heard of Arthur Ashe. Arthur Ashe used to be a really, really excellent tennis player. And he was feeling a little tired. He wasn't sick. He just felt tired. So they gave him a couple units of blood to perk him back up. Well, one of those units of blood was infected with hepatitis. I don't know which one, probably C, but I'm not real sure. So don't quote me on that. But it was infected with hepatitis, and he ended up dying from hepatitis. And just because he wanted to get a little perk up. That's such a sad. That was before 1992, and that's kind of when all this was starting to become known about hepatitis and HIV. Hemodialysis patients have an increased risk for hepatitis B. Again, close person-to-person contact with cuts or sores, and again, those immunosuppressed are at greater risk. The clinical course of hepatitis B patients does vary. The symptoms usually occur within 25 to 180 days of exposure, so who can remember 6 months back what you did? But those symptoms would be anorexia, nausea, vomiting, fever, fatigue, right upper quadrant pain, dark urine with light blood perhaps, joint pain, jaundice. That joint pain thing we'll be talking about that shortly. Blood test confirms the disease. Most persons do recover and clear the virus from their body and develop immunity. Well, I guess that's not the one Arthur Ashe had because he didn't recover. I wonder if he had HIV. I don't know. I'll look it up, let you know. Some do not develop the immunity, and they don't have the symptoms. They just don't also have the immunity, and they're just carriers. And these people are at high risk for cirrhosis and liver cancer because they don't even know that they have the problem. They don't have the immunity against the problem, and it just keeps cooking them inside them. The incidence is increasing due to newcomers entering the country from endemic areas. So that's what happens. And I don't want to get into political discussions. I really don't. But when we have people coming into our country and we have no ability to know who they are or what disease they're bringing in with them, we are going to be affected. That's just the bottom line. And we're starting to see it, or we have been seeing it with hepatitis B. It's just the way it is. Hepatitis C is the third type we're going to talk about. The causative virus on this is an enveloped single-stranded RNA virus, and it's transmitted by blood to blood. The rate of transmission is very low in monogamous couples. In couples who are not monogamous and have several sex partners, the transmission rate goes up. It's spread mostly by illicit IV drug needle sharing. That's the highest incidence of transmission method. Needle stick injuries, the blood and blood products or organ transplants prior to 1992. Again, there's the needle stick injury, unsanitary tattoo equipment, sharing of intranasal cocaine paraphernalia. It's not transmitted by casual contact or intimate household contact. So it is not sexually transmitted unless there's potential for the women, if she has any vaginal tears, it could. But it is recommended that those who are infected do not share razors, pierced earrings, or toothbrushes, which kind of made me cringe because who does that anyway? Don't use my toothbrush. Okay, average incubation period is 7 weeks. Acute infection and illness are not common. They're usually asymptomatic and not diagnosed until many months or years after initial exposure. So they may not know they have this for a long, long time. They do not clear the virus, and the chronic infection state develops. Over the decades, it causes liver cells to scar due to chronic inflammation processes. Now, I know you've heard of Winona Judd, right? You know Winona, and her mother, Ashley? No, that's her sister. Naomi Judd. Naomi has chronic hepatitis C, and that's why she stopped going on tour, because she needed to rest. That's the treatment for hepatitis, is to rest, rest, rest. It's quite emotional. I remember watching her do her final concert, and it was quite moving, but she's doing all right. Hepatitis D is caused by defective RNA virus that needs the helper function of the hepatitis B virus. It only occurs with hepatitis B to cause viral replication, and this usually developed into chronic disease. The incubation period for this is 14 to 56 days. It's transmitted primarily by parental routes, especially in the IV drug users, and sexual contact with hepatitis B infected persons increase the risk. So you really don't need to know much about this one other than it's transmitted IV and sexual contact, and it's very, very rare in our country. The final hepatitis we're going to talk about is hepatitis E. It is a waterborne infection. And these are associated with epidemics in the Indian subcontinent, Asia, Africa, the Middle East, Mexico, and Central and South America. Many large outbreaks occur after heavy rains and flooding. So when you hear of the tsunamis out in the Asian area, you know that you're going to maybe also start hearing some hepatitis E type infections going on. It's caused by fecal contamination. It is only found in international travelers in the United States. It has an incubation period of 15 to 64 days. There is no evidence of a chronic form, and it's usually self-limiting and self-resolving. Right now, they probably don't even know they have that one. Complications of hepatitis. It's considered to be chronic if it lasts greater than 6 months. It's usually a result of hepatitis B or C. Those are the two most common ones. Can lead to cirrhosis and liver cancer, and many of these patients have multiple infections. They don't have just hepatitis. They got a lot of stuff going on. Fulminant hepatitis is the failure of liver cells to regenerate with progression of the necrotic process. It is acute and often fatal. I believe this is the one that got Walter Payton. Oh, I love Walter Payton, sweetness, number 34, the Bears. But he had hepatitis, liver disease, and I always wondered, why didn't they give him liver transplant? But if they can't regenerate, it killed him. That was so sad. my God, he was such an awesome person. Oh, hepatitis. Prevalence. Incidence is declining of hepatitis A and hepatitis B as a result of CDC recommendations for vaccinations. About 200 million people worldwide have hepatitis C, and that makes this the most common type. There is no vaccine for hepatitis C at this time. How do we promote health? How do we prevent? What's our hepatitis plan? It's to vaccinate infants, children, adolescents, healthcare workers, policemen, anybody at risk of being exposed to bite injuries, needle sticks, blood products, any of us, okay? So pretty much all of us. Proper hand washing, of course, will help. Avoid contaminated food and water. If you get exposed to hepatitis, receiving an immunoglobulin within 14 days of exposure will help prevent actual exacerbation of the disease. It's recommended to receive the hepatitis A vaccine before traveling to high-risk areas. And receive the vaccine if living or working in enclosed areas with others, and specifically mentioned in your book with the college dorms, correctional institutions, daycare centers, long-term care facilities. So important for anybody living in close quarters with pretty much strangers to have vaccinations. The vaccinations that they have for this hepatitis A, it's Havrix and Vacta. Hepatitis B would be Injectix B and Recombavax, which is the one that I got. You get through a series of 3 with that. It's probably what you guys got as well. Hepatitis A and hepatitis B together will be a Twinrix, okay? High-risk groups where hepatitis B vaccines would be most helpful are listed here, and that's your non-monogamous persons, persons with STDs, men having sex with men. Why not women having sex with women, you may ask? Well, think about the process and realize who has got a greater risk of infection due to abrasions and entry into skin areas. It's not going to be the women, okay? Persons with chronic liver disease, persons with immune deficiency, those exposed to blood or body fluids in the workplace, and again, those healthcare workers, firefighters, the policemen, incarcerated persons, persons needing immunosuppressant drugs, and family members or close contact persons of people with hepatitis B infection. So really pretty much anybody. What assessment should we do on our hepatitis patients? Well, let's do that. Let's start with a history, okay? We're going to go right down the list here. Have they been around anybody with hepatitis? Have they been exposed to either inhaled or ingested chemicals? How about their herbal supplement use? Have they been on any new prescribed drugs or over-the-counter medications? Have they recently ingested shellfish? Have they been on international travel lately? What are their sexual activities? Not specific, but you know what I mean. What is their sexual orientation? And, well, I'm going to move on. Illicit drug use, IV or intranasal, recent needle stick exposure, the tattoos or body piercings. Do they have close living accommodations? Have they ever received blood or blood products or an organ transplant prior to 1992? Were they in the military? Did they do military service? I tell you, those guys, we in the military, we are vaccinated against everything. We're vaccinated from typhoid, for God's sake. But anyway, they are high risk for tattoos and stuff, but I know they've gotten their vaccines. I know it. I've been there, done that. Place of birth, parents' place of birth, are they born outside the country and so therefore at a higher risk of having the disease and not knowing it from previous where they lived. History of alcohol use and how much per day, and what is their HIV history. The physical, we want to do an abdominal exam. Is it tender? Where is it tender? Do they have changes in the skin or sclera? Any evidence of jaundice? Look at the whites of their eyes. Are they jaundiced in their eyes? Arthralgia or myalgia, those are the joint problems that can happen because of as one of the extraterrestrial, right? Extraintestinal symptoms. Diarrhea or constipation, changes in the color of urine or stools, dark urine, clay-colored stools result from the intrahepatic obstruction problem. Fever, lethargy, malaise, nausea, vomiting, pruritus. It's presence of skin abrasions because they're itching. The psychosocial. Emotional problems may center on their feeling sick and fatigued. Depression, promoted by general melee and activity, vague symptoms. Guilt feelings and remorseful if it was in a way self-inflicted by social behaviors. Embarrassment due to the diagnosis. There is a social stigma to hepatitis, even though a lot of it is not due to anything other than that's not due to social behavior problems. Family members may distance themselves due to ignorance and a fear of contracting the disease, so you must teach them what safe behavior would include. And then the lost wages during the acute phase when they can't go to work, when they need to rest. And again, think of Naomi Judd and her psychosocial. Yeah, she's a star. She's got everything at her disposal, but she still went through all that. The labs, we'd want to, hepatitis is diagnosed by acute elevations in liver enzymes. The ALT and AST may rise dramatically in that acute fulminant case. Serum bilirubin will be elevated. Presence of antibodies for hepatitis A, B, D. You're going to see the antibodies to those in the blood if you screen for that. Enzyme-linked immunoabsorbent assay, which is the ELISA, is the initial screening test for patients suspected of having hepatitis C. The diagnostics would be a liver biopsy to establish the diagnosis and the stage and grading of the liver damage. What is the management for hepatitis? It's based on measures to rest that liver, promote cellular regeneration, prevent complications. So rest, rest, and more rest. Rest. A diet high in carbohydrates and calories with moderate amounts of fat and protein after nausea and vomiting subside will help. Small frequent meals is often better tolerated. High calorie snacks, supplemental vitamins, and drugs are used very sparingly. Due to the life-threatening nature of chronic hepatitis B and C, a number of drugs are given, including antiviral and immunomodulating drugs. So only when there's a life-threatening nature do we want to, use medications that the liver has to process. Teaching. What do we teach these people? Hand wash, food wash. Should put food washing on here too. Sanitary disposal of human waste products. And I should also add on here, do not go to San Francisco right now. And we're in cholecystitis. What is this? Cholecystitis is inflammation of the gallbladder. It affects many people and is most common in the affluent countries. It may be acute, it may be chronic. The acute has two types. We'll talk about each of them individually. The first one we'll talk about is calculus. Sounds like a math class. It's the most common of the two types of the acute, and the pathophysiology of that, this one is abnormal metabolism of cholesterol and bile salts. The stones are easily created in the gallbladder because it only occasionally mixes its normally abundant mucus with its highly viscous concentrated bile. So it just kind of like, it sludges, just sludges. It's kind of a stasis type situation. Impaired gallbladder motility can lead to stone formation by delaying bile emptying and causing that biliary stasis. So it just kind of hangs around in there and clots up, not clogs up. Gallstones are composed of substances normally found in bile, and this would be cholesterol, bilirubin, bile salts, calcium, and various proteins. Bacteria can collect around the stones, and if it's severe enough, it can lead to life-threatening suppurative cholangitis. So it's, yeah. Chemical irritation and inflammation result from the gallstones. It's called cholelithiasis. That's what gallstones are. And so because the gallstones are in there, it irritates the walls of the gallbladder and it gets it inflamed. And when the gallbladder is inflamed, trapped bile is reabsorbed and it acts as a chemical irritant to the gallbladder wall. So just hangs out in there and annoys it. Reabsorbed bile in combination with impaired circulation, edema, and distension of the gallbladder causes ischemia and infection. This causes tissue sloughing with necrosis and gangrene within the gallbladder itself. The gallbladder may eventually perforate. If it's a small perforation, abscesses may form. If it's a large perforation, peritonitis may occur. It needs immediate treatment either way. The acute number 2 is acalculous cholecystitis. Imagine that, calculus and acalculus. Anyway, this is inflammation occurring without the gallstones. It's associated with biliary stasis caused by any condition that affects the regular filling or emptying of the gallbladder. In other words, there's a decrease in blood flow to the gallbladder or anatomic problems such as a twisting or kinking of the gallbladder neck of the cystic duct. And this causes pancreatic enzyme reflux into the gallbladder, which results in inflammation. So just know that the acalculous one doesn't involve calculi, stones. It's just a movement issue. The sphincter of Oddi dysfunction can occur also to cause reflux and inflammation in patients with sepsis, severe trauma or burns, long-term TPN, multi-system organ failure, major surgery, and hypovolemia. So look up the sphincter of Oddi, find where that is. I should have put a diagram here, but I didn't. You can look it up. And finally, for the cholecystitis, let's talk about the chronic. It results when repeated episodes of cystic duct obstruction causes chronic inflammation. So it comes and goes, comes and goes, comes and goes. Calculi are almost always present in this one. Gallbladder becomes fibrotic and contracted, and it results in a decreased motility and deficient absorption. Pancreatitis and cholangitis, which is bile duct inflammation, can occur as complications. It results from backup of bile through the biliary tract, which leads to the jaundice. Jaundice and icterus. What's icterus? Do you know what that is? Look into my eyes. Are mostly commonly seen in the chronic form of the disease. With obstructive jaundice, the bile salts back up into the skin, causing pruritus or burning sensation. So that's where they're going to get the itching, the bile salts. Bile flow blockage also prevents bilirubin from reaching the large intestine, where it is converted to urobilinogen, which is why the feces is clay-colored. Urobilinogen is what causes our stools to be brown, and if it can't get there, it doesn't get turned brown, so it stays clay-colored. Urine becomes dark and foamy because the kidneys are trying to clear the bilirubin. Interesting, huh? Kidneys are doing what they're trying to do. There's a familial or genetic influence on cholecystitis, but it may be due to familial nutritional habits and sedentary lifestyles rather than any genetic thing. Risk factors would be obesity, type 2 diabetes, dyslipidemia, insulin resistance. It's increased in age, female gender, and family history. Those who experience rapid weight loss and certain intestinal diseases affecting the normal absorption of nutrients, such as Crohn's, are at an increased risk of cholecystitis. American Indian and Mexican American populations have the highest risk of gallstones. I don't know why. The incidence is increased in young, thin women who are athletic. I should be safe. What type of assessment do we need to do on these people? Let's just do the physical here, height, weight, vital signs. Okay, let's start there. Inquire about their food preferences. Do an assessment of the amount of fat and cholesterol that they take in. Diets high in fat, calories, refined white carbs, and low fiber are at a higher risk of gallstones. Inquire if any foods cause pain, especially when fatty foods are eaten. Do a pain assessment, the intensity, duration, any associated factors. What measures do they do to relieve them? My sister had acute cholecystitis, and it was kind of chronic because she didn't get it treated right away, and the doctor finally told her, you'll get to a point where you want me to take it out. But what she would do, she'd get in the bathtub. She'd be in the bathtub 2 in the morning taking a hot bath, relieving it. But he was right. She finally got annoyed enough that she had it removed. But anyway, what relief measures are they doing to help get through the episodes? They may describe it as an indigestion, specifically up under the right upper quadrant of the abdomen. This pain may be vague and unspecific, kind of radiating everywhere. It might be localized around the umbilicus. They may refer to them as gallbladder attacks, okay? The severe pain is produced by the obstruction of that cystic duct of the gallbladder or movement of one or more stones. It's annoying and it hurt. Big stone trying to get through a tiny little duct. Ouch! Describe their daily activity or exercise routines. Are they sedentary is really what we're trying to figure out. Taking any current or previous hormone replacement therapy or birth control pills, that can affect the motility. Assessment for rebound tenderness, which is called Bloomberg sign, is only done by the physician or advanced practice nurses. We are not to do those as nurses. Stool assessment, steatorrhea occurs because fat absorption is decreased due to the lack of bile. Bile is needed for the absorption of fats and fat-soluble vitamins in the intestine. So if they don't have it, this fat's going to come out in their stool. Vital signs may have elevated temp, they may have tachycardia, and they may have dehydration symptoms from fever or vomiting. Diagnostically, the labs will see an increase in the white blood count, the AST and LDH, and bilirubin levels will be elevated. You'll see serum amylase and lipase levels elevated if the pancreas is getting involved. X-rays will show those calcified gallstones, but it will not detect stones that have not yet calcified. In other words, they're not yet stones. I shouldn't have said that, but if it's not yet developed into the stone phase, you're not going to see that. The ultrasound of the right upper quadrant is the best initial diagnostic test. Our differential diagnosis, in other words, what else could it be that we have to consider, would be, of course, peptic ulcer disease, hepatitis, and pancreatitis. It mimics those three, so it's very important to distinguish what's really going on. And of course, that's the physician's job, but our job is to get as thorough of data as we can to make his or her job more as accurate as possible. How do we manage these? There's surgical and non-surgical. The non-surgical methods would be nutrition, where we have them avoid fatty foods. If they have nausea and vomiting, withhold food and fluids, and do IV therapy for hydration. This is interesting. Extracorporeal shock wave lithotripsy, ESWL. This can be used only for patients who have a normal weight, who have cholesterol-based stones, and a good gallbladder function. The patient will lie on a water-filled pad, so I'm thinking they're on a waterbed, and the shock waves break up the large stones. Just shake it all up into smaller ones, and these smaller stones can be passed through the digestive system more easily. So that's my picture of it, shaking it. So the shock waves. They may have pain during the procedure from the movement of the stones or because of gallbladder spasms. Therapeutic bile acid, UDCA. Ursodeoxycholic acid. I'm sure that's wrong. Ursodeoxycholic. Well, anyway, UDCA may be used after the procedure to help dissolve the remaining stone fragments. So that's kind of one of the newer ways to deal with that, and I thought it was pretty cool. Drug therapy. The acute biliary pain requires opioid analgesia. Antiemetics to help with the nausea and vomiting. Toradol may be used, the NSAID, because for mild to moderate pain. And we need to be sure to monitor the patients on Toradol or NSAIDs for signs and symptoms of GI distress and pain because of its effect on the GI tract. Surgically, for the acute, emergency cholecystectomy via laparoscope. For chronic, cholecystectomy, but it's not emergent. So that would be my sister. She had chronic. Cholecystectomy via the laparoscope is the gold standard for surgical management. So that laparoscope is the deal there. Not doing a whole abdomen, but just going in, 2 little holes in it. The post-op instructions that I'm going to tell you will be actually for the laparotomy patient. The first couple instructions here, those are the ones that have the full abdominal laparotomy. Your laparoscopic patients are going to recover quite quickly, and they're usually discharged from the hospital on the same day. They can usually eat as soon as they're able to be awake and swallow and all that. But with the laparotomy patient, we're going to keep them NPO until they're fully awake. We advance their diet from clear liquids to solid foods as peristalsis returns, and they're usually on regular food by 1 to 2 days. Initially, these patients may need to be on a low-fat diet to reduce discomfort and prevent nausea, and that may be true of your laparoscopic patient as well. Most patients do not need a special diet. We advise them to eat nutritious meals and avoid excessive intake of fatty foods, especially fried food, butter, and fast food. If they're obese, let's talk to them about a weight reduction program, see what their motivation is, and help them achieve that. Keep the incision clean and report any changes that may indicate an infection. Now, it's true of either the laparoscope or the laparotomy, but of course the laparotomy has a bigger incision, so it's very important that they learn how to keep that clean and identify early signs of wound infection. We want them to report repeated abdominal or epigastric pain with vomiting and diarrhea that may occur several weeks to months after surgery. So if they continue to have problems of that nature for months, for several weeks, we want them to report that to the surgeon. And that's it on cholecystitis, and that's it on inflammation of the lower GI tract exemplars.